हाय मलिया. स्टार्ट करें अपन.
Yes, yes.
ओके. Ah, all right. Okay, so let's start with the respiratory system today. So respiratory system, one of the smallest system, and many direct questions have been asked. There is so much link to the microbiology over here, and so we'll be doing this. And let's just begin with the embryology part. In embryology, you just have to remember this term. Every pulmonologist can see alveoli. Okay, in mnemonic, you have to remember every pulmonologist can see the alveoli. And in this part, you just have to remember this. Airways increase in diameter, pneumocyte develops starting at week 20, respiration capable of week 25. Okay, so in the case, they might give you like a baby started breathing on its own and all those stuff, and at the end, what do you think is the time, like when the respiration started? So they can ask question like this directly. Okay, so airways increase in diameter, pneumocyte develop starting at week 20. This is an important line that you need to know. And yeah, and before the 17 week, respiration impossible, incompatible with life, because lungs haven't been matured yet. Okay, so these are the things that you need to remember for now. Okay, and just remember this mnemonic. They might ask you the time period and the name of the development. Okay, in UWorld there was one question regarding this, ki, till what to what layers it is there, but I haven't found any question in NBME, neither in any mock test. Okay, so I don't think it's important, so let it be. And let's move ahead. Yeah, this is a visual representation of what they have given over here. This mnemonic one. So this is a visual representation. Just give it a look. Don't focus so much over here. Okay. This choanal atresia. It is a topic of ENT, the nose part. It wasn't given in 2020 edition, but they have added here. So let's just see. Blockage of the posterior nasal opening, often associated with bony abnormalities of the midface. Okay. How it represents it, emergency and present with upper airway obstruction, noisy breathing, cyanosis that worsens during feeding and improves with crying. Okay. Diagnosed by failure to pass nasopharyngeal tube and confirmed with CT scan. This is a new topic that they have added. Okay. It wasn't there in 2020, wasn't there in 2021. I think 2022 is the one. Okay. So just note this down. In this page, only this much is important. Every pulmonologist can see alveoli. This much is important. Okay. Moving to the next page. Lung malformation. Yeah, this is important. Pulmonary hypoplasia. Poorly developed bronchial tree with abnormal histology associated with CDH, that is congenital diaphragmatic hernia, usually left-sided, bilateral renal agenesis. Here they will ask you one question if you have solved UVL. In that, they might give you what is the basics of CDH, what actually happens in the anatomical base. Anatomical basics may what it happens. Okay, so one simple line you need to remember everywhere, and that is non-development of pluriperitoneal folds. Okay, so non-development of pluriperitoneal folds. This is what you need to remember when there is a question of congenital diaphragmatic hernia. So, Ishan Maliaji, any one of you can give me the clinical presentation of congenital diaphragmatic hernia? Anyone? क्या क्या हो सकता है? बोलो बोलो. Think.
नहीं मालूम.
Yes, yes, Isha, what did you say?
नहीं पता.
अच्छा नहीं पता. Okay, तो चलो. I'll tell you. Congenital diaphragmatic hernia है. So it means कि all the intestinal contents will enter the thorax. Okay. It will be mostly left sided and is easily given over here. Left sided में होगा. So when you see on chest X-ray, you will find the loops of intestine. You can see, you can hear the abdominal sounds on chest. And yeah, this only. Yeah, this only. And they might give you the diagnosis congenital diaphragmatic hernia. After that, they will be asking you this non-development of pluriperitoneal fold. Okay, this is very important. You will may I think 2 to 3 questions are there. So just remember this. Next is bronchogenic cyst. I don't think any one of the questions have been asked. So there are so many cyst questions that have been asked that are I think in neuro part, that is cystic hygroma, and in endocrine you have thyroglossal cyst. But bronchogenic cyst I haven't seen any question. Uh, there was one question in the retired NBME. Okay, but after that not a single question has been asked, so you can avoid it. Club cells, non-ciliated, low columnar cuboidal with secretory granules. That's it, nothing else. Moving on to alveolar cell type. These are little important. Give it very important because questions have been asked on regular basis. So type 1 pneumocytes, squamous, 97% of alveolar surface, thinly lined the alveoli for optimal gas exchange. So gas exchange is responsible by type 1 pneumocytes. Moving on to type 2 pneumocytes, cuboidal and clustered. Okay, cuboidal and cluster have two functions. Serve as a stem cell precursors, both for type 1 and type 2, proliferate during lung damage. And second, secrete surfactant from laminar body. So sometimes they, most of the time they will ask the question, the lungs were damaged, the cells, so lung damage had the pneumocytes will also be damaged. At the end, they will ask you what type of lung cells are responsible for regenerating the lung tissue. So your answer will be type 2 pneumocyte. Okay, this is important one. So this serve as a stem cell precursor. It means it helps in the regeneration of the lung tissue, which is important point. Second, it helps in the surfactant synthesis. Yeah, it helps in the surfactant synthesis. Now, what is surfactant and why it is important? Let's just see. Surfactant. It decreases the alveolar surface tension. It decreases the alveolar collapse. It decreases the lung recoil, and it increases the compliance. These parameters are very important. Mark it high yield. So many questions have been asked regarding the parameters. Okay. Now, what is this surfactant? Composed of multiple lecithins, mainly dipalmitryl phosphatidylcholine (DPPC). Again, this is very important. Okay. Synthesis begins 20 weeks of gestation and achieves mature levels by 35 weeks of gestation. Glucocorticoids important for fetal surfactant synthesis and lung development. Now, why this line is very important is because there might be premature birth. Okay, and when there is premature birth, the lungs are not developed yet. Lungs are not developed yet. As a result, the surfactant is not developed, and the baby won't be able to breathe by itself. Okay, this surfactant is very important, and all these parameters that we have marked here: decrease in alveolar surface tension, decrease in alveolar collapse, decrease in lung recoil, and increase in compliance. These are very, very important parameters. They will be asking you in the form of arrows: increase, decrease, increase, decrease, increase, decrease. Okay, so they will be asking you like that. Okay, that's it. Let's move on to the alveolar macrophages. Phagocytosed foreign materials release cytokines and alveolar proteases. Hemosiderin-laden macrophages may be found in setting of pulmonary edema or alveolar. Nothing important, just this line. Phagocytosed foreign materials. That's it. The main part being the type 2 pneumocyte. Two functions we have studied. It helps in the regeneration of lung tissue after injury, and second, it helps in the synthesis of uh, surfactant. And yeah, I forgot another important point over here, that is proliferate during lung damage. Another question that they might ask here is if there is any lung damage, okay, lung inflammation, they might ask you what type of cells proliferate or what type of cells you will be seeing on the histology. Your answer will be type 2 pneumocyte. Okay, so these are very, very important questions. They have been asked repeatedly. So this alveolar cell type become pretty high yield. Okay, just notice down what I have written and then we'll move to NRDS. I hope your micro is strong because today we'll be discussing so many things regarding microbiology. Okay, while we study the pneumonia part. All right, let's move on to NRDS. NRDS, neonatal respiratory distress syndrome. Another very, very high yield. Questions have been frequently asked. Here, what happens? Surfactant deficiency. So, what will happen? All the parameters that we studied here, there will be opposite of that. Okay. So, increase in surface tension, the increase in alveolar collapse. Okay. Another important thing: ground glass appearance of lung fills. Ground glass appearance of lung fills. Now, see. Let's see the risk factors over here. Prematurity, diabetes during pregnancy, C-section, and decrease in release of fetal glucocorticoids. Okay, so these are the factors, these are the cases that they will give you, and then you have to analyze whether the baby will be suffering from NRDS or not. Okay, moving ahead. Treatment: maternal glucocorticoids before birth, exogenous surfactant for infant. Okay, so before birth you can give the glucocorticoids to the mother. Okay, therapeutic supplemental O2 can result in retinopathy of prematurity. We did this while we were studying the general pack. Okay, ROP. This you have studied in ophthalmology. So if the newborn baby is directly given so much of oxygen, it can lead to retinopathy of prematurity. Okay. Another, intraventricular hemorrhage, bronchopulmonary dysplasia. Okay, so all these things can be related with NRDS. How? Because when you diagnose baby with NRDS, you won't be giving so much oxygen to the baby. If you give so much oxygen to the baby, it will lead to ROP. This is the most frequently asked question in the exam. Okay, now another important question that they like to ask is screening test for fetal lung maturity. Lecithin sphingomyelin, LS ratio. Okay, lecithin sphingomyelin ratio in amniotic fluid. They have also asked the values. Greater than 2 is LD, less than 1.5 is predictive of NRDS. Okay, so make sure you know this. All this is very, very important, and I mark this again very, very high. So note all these points. I'll repeat. There is deficiency of surfactant. So whatever you studied in the surfactant part, there will be totally opposite of that down. Risk factors are prematurity, C-section being the most commonly asked. Okay, how you will treat? Give the mother corticosteroid and give a surfactant inhaler to the baby. Next, if you give so much oxygen to the baby, then what will happen? There will be retinopathy of prematurity, ROP. This is the most commonly asked. Next, how to diagnose NRDS? Just simply check for the LS ratio. If it is greater than 2, then the baby is healthy. If it is less than 1.5, then your diagnosis NRDS. Simply. Okay, nothing new. All this you have studied earlier, and this is what they like to ask. Okay, coming to the anatomy part of respiratory, conducting zone and respiratory zone. This is the basic, and you should remember what cells are there in what part of the zone. Okay, so this diagram is high yield. Just remember that. Okay, it's okay. Don't remember the diagrams and all those stuff. Just remember what is there in the conducting zone and from where the respiratory zone starts and what all cells can you find. So in this only, this information is very good. Just give a read and try to remember if possible. Okay, not so many questions have been asked, one or two only, but this is the very easy information. I don't want you to miss it out. All right, moving ahead. Lung anatomy over here. Right lung has three lobes, whereas left lung, one of the region is occupied by heart, so it has two lobes. Moving now, you can ignore this. You can ignore this. What important over here is they will be asking you that right lung is a more common site for inhaled foreign body. Okay, because right main stem bronchus is wider, more vertical, and shorter than the left. This is one question for you. Wider, more vertical, and shorter. Wider, more vertical, and shorter than the left. Okay, this is how you remember. Wider, more vertical, and shorter than the left. Okay, because one question was there in NVMe regarding this only they gave in the form of arrows. So this is how you will be remembering. Okay, so this was important. Now they will ask you another question over here. If you aspirate a peanut, okay, so in the question they will give you a small baby, a small boy or a children, a child came to you. He was sleeping while having peanut, and now he is choking. Okay, so on in what part of the lung the peanut was aspirated, or where the peanut is located, and in what part of the lung? Okay, so while supine usually enters the superior segment of right lower lobe. So this okay, this is the lower lobe. So if you are supine, it will occur the superior segment of right lower lobe. Second, while lying on the right side, usually occurs at the right upper lobe. If you are lying on the right side, right upper lobe. Third, while upright, usually enters the right lower lobe. So in the right lower lobe, it can be anywhere. This is very important. Okay, this you have to remember. Okay, the three cases I have made for you, and this one question directly wider, more vertical, and shorter than the left. Okay, so make sure you remember this. You should know how to read, like how to identify the structures on the abdominal X-ray or chest X-ray. Okay, because not only about the lung, they will be asking you about many pathologies when we study the system wise. I'll let you know. but give the habit of reading more and more chest x-rays or abdominal x-rays. They are going to help you a lot. So many questions will be asked based on your radiology part. Okay. Coming to the diaphragm structure. In the diaphragm structure, perforating diaphragm. This is very important. T8, T12, T10. I ate 10 eggs at 12. This is how you will remember. And you have to remember what all passes at what structure. Okay, so all these are very important. Now, what will happen is sometimes they will say if there was a perforation in the diaphragm. Okay, there was a perforation in the diaphragm. How you will know if perforation is occurring in the diaphragm? Okay, how you will know without looking at the chest X-ray or MRI, whatever you want to do. But before that, how you will know that perforation or a problem is in diaphragm? Simple. In the question itself, they will be giving you diaphragm is innervated by C3 to C5 phrenic nerve. Pain from diaphragm irritation can be referred to shoulder and trapezius ridge. Okay, shoulder and trapezius ridge. If there is a pain, if you are sitting like this and the patient is having pain over here or on the trapezius, then close your eyes and go for a diagnosis that there is some problem with the diaphragm. Okay, as simple as possible, and they will be asking you the root values of the nerve. So phrenic nerve ka root value is C3 to C5. Okay, so this becomes very very important. Now they have given one radiological point that they have added here. Okay, it wasn't given in 2020. I'm just writing it here. Phrenic nerve injury causes elevation of ipsilateral hemidiaphragm on the X-ray. Okay, ipsilateral. That means on which side the phrenic nerve is injured, on the same side that diaphragm is elevated. Okay, so this is one radiological finding that they have given. Ignore this, but you have to remember this mnemonic is very very helpful. I ate 10 eggs at 12, and this is what you need to remember. Okay. One important point I would like to add over here. This is not given in first aid, so write it down. Irritation of phrenic nerve can cause dyspnea and hiccup. Okay. If you cut the nerve, there will be diaphragm elevation, and this is what will lead to dyspnea. Okay. Um, So irritation of phrenic nerve can cause dyspnea and hiccup. If you cut the nerve during any surgical procedure, there will be elevation of diaphragm and it will cause dyspnea. Okay. So this is all important that you need to remember. Just note this down quickly, then we'll finish with the anatomy part. We'll move on to physiology. Alright, let's move on to physiology part. Now see, I know this might be very difficult to learn, lung volumes and capacities. So if you take my suggestion, leave this. Okay, because no matter how much you remember in the exam, you are going to forget it. Okay, no much. अभी कितना भी मेहनत कर लो एग्जाम में याद नहीं आने वाला है. Okay, so instead of this what you do is I'll let me show you one pic. Okay, see, this is the diagram, this is the pic that I want to show you. These are all the volume. Just remember कि obstructive lung disease में ऐसा होता है and restrictive में ऐसा होता है. Just remember, in obstructive it will be like this, in restrictive it will be like this, because uh, like lung volume, they will be asking you questions like this only. They won't ask you the direct definition. What is the type of what is the lung volume that changes on inspiration, or inspiratory capacity का formula? All they won't be asking you that. They will be asking you in a application way, and Just remember, obstructive lung disease like bronchitis, emphysema, asthma, all those stuff then come. This will be the answer. And if restrictive, like pneumoconiosis and all those stuff that we study, if that comes, this should be your answer. And this is what normal looks like. So instead of mugging up those volumes, just give a look at this. If that comes in the question, we are definitely going to forget. So it's better, don't waste time on that. Do as per your life. Okay, my suggestion would be leave that part. Still, if we are going to do that, let me just tell you what is very, very important over here. So residual volume is very important. Air in lung after maximal expiration. RV and any lung capacity that includes the residual volume cannot be measured by spirometry. Okay, RV cannot be measured by spirometry. And what is the definition? Air in lung after maximal expiration. RV and any lung capacity. Okay, okay. So how much you expire, some volume of air is already always going to stay inside your lung, and that is what known as RV. Okay, this is very important. Rest all, just give it a read and memorize as per your mnemonic or all those what you know. Okay, work of breathing. This is a new topic that is not given in an old edition. So let's just see what they have given here. Refers to the energy expended or O2 consumed by the respiratory muscle to produce the ventilation needed to meet the body's metabolic demand. Comprises the work needed to overcome both elastic recoil and airway resistance. Minimized by optimizing respiratory rate. This is very important. Minimized by optimizing respiratory rate and VT. In restrictive disease, increase work to overcome elastic recoil achieved with increased RR and VT. See, this is a new topic, and why they have given it here? Because UWorld has so many questions. Okay, I think 3 to 4 questions are there in UWorld regarding this. They've asked about the work of breathing, and they have always played with the parameters, respiratory rate and VT, that is tidal volume, I think so. Okay, and in obstructive disease, decrease in RR and increase in VT, increase in RR, decrease. I'll write for you if this is not in your book. Obstructive and restrictive. RR respiratory rate and VT is tidal volume. So in restrictive disease, RR is increased, tidal volume is decreased. Whereas in sorry. In restrictive disease, RR is increased and VT is decreased. Whereas in obstructive disease, RR is decreased and VT is increased. Guys, this is very important. I am telling you. Though it was not given in the old books, so many questions were there in UL and even NBME has this question. So write this down if it is not given in your book. This is very important. Ignore this. They won't ask you to determine the physiological dash space. Okay, so don't worry. Just write this down. This is very important. Yes, so today in the class we have Malia ji and Isha ji. आप दोनों ही लास्ट यूवल स्टेज पे हो. Okay, and both of you are going to give the exam in the upcoming month, in a month or two. Okay, both of you are in the end stages of your preparation. Both of you were like in my guidance session. So if you want, you guys can discuss later and do what if you want, or else you can do your own ways, no matter. But you can think about this. Okay, moving ahead. Ventilation, minute ventilation, alveolar ventilation. No questions have been asked. So just remember this formula. VE is equal to VT into RR, that is minute ventilation, and alveolar ventilation is this. Because sometimes uh, how they like to ask the question in respiratory physiology is they will be giving you all these parameters, and then they will ask you, will the minute ventilation increase or minute ventilation decrease? Okay, so during that time you just have to remember the parameters and the relation. Now if they ask you what is the level of minute ventilation when VT is increased or RR is increased, so you have to apply the simple mathematics. Okay, ओके सिंपल मैथमेटिक्स का रूल लगाना है. अगर RR increase हो गया, so VE will decrease. Okay, simple mathematics is there. So you just remember, try to remember this formula, and in the exam all the parameters come up. Just apply this formula and measure the parameters mathematically. Okay, lung and chest wall. Here what you need to remember is this diagram. Okay, intrapleural pressure, this is alveolar pressure and lung volume. So you ignore this, but alveolar pressure is like this and intrapleural pressure is always negative. Okay, so guys, see, respiratory physiology is going to be very tough on the exam. So if you haven't read the book BRS physiology, I would highly recommend you to do this right now. It's okay even if you are solving UL right now, but this book is going to be a boon for you, okay? And it will help you to solve questions much easier. Not all the questions will be solved, but 80% of the questions will be solved, because no matter how much you do, respiratory physiology is going to come very tough, okay? So you can refer this book. Let's just see. Lung and chest wall. Because of the histological reasons and small pressures, pulmonary pressures are always present in HQO. Okay. Elastic recoil. Tendency for lungs to collapse inward and chest wall to spring outward. Okay. At functional residual capacity, airway and alveolar pressures equal atmospheric pressure. The inward pull of the lung is balanced by the outward pull of the chest wall. System pressure is atmospheric. Pulmonary vascular resistance is at a minimum. So what all you need to remember here is, at functional residual capacity, airway and alveolar pressure equal atmospheric pressure. This is the first point that you need to know. The inward pull of the lung is balanced by the outward pull of the chest wall. This is the second point. And the pulmonary vascular resistance is at a minimum. When does this occur? At functional residual capacity. Okay, functional residual capacity पे there will be this airway and alveolar pressure equal. Inward pull of the lung balanced by the outward pull of the chest. And third, pulmonary vascular resistance is going to be at a minimum. So this is very high. Okay. Moving on to compliance. What's given in compliance? Change in the lung volume for change in the pressure, that is delta V by delta P. Inversely proportional to wall stiffness and increased by surfactant. Okay. Increased by surfactant, we saw that earlier. Okay. Compliance increase with a surfactant. Only then the lung size will increase and you will be able to breathe properly. Okay. So increase in compliance, lung easier to fill. Decrease in compliance, lung more difficult to fill. And here you need to remember this example. Emphysema, older adults, fibrosis, pneumonia, age. So this is very high. Okay. In which of the conditions compliance increase, in which of the conditions compliance decrease. So जो brackets में दिया है, whatever is given in the bracket, very important. Okay. So this is how lung and chest wall part has become very important for you. Okay. So many questions have been asked from here. Okay. Note this down, whatever you want to note it, and then we'll move forward. Give me a minute. All right, let's move forward. So in the forward, this also there is another important thing, hysteresis. Lung inflation follows a different pressure volume curve than lung deflation due to need to overcome the surface tension forces in inflation. Now see, just ignore whatever it is said over here. Just remember this diagram. See, this green one, it is a normal. If the curve goes above, then there will be COPD. If a curve goes below, there will be RLD, obstructive lung disease and restrictive lung disease. Okay, just remember this thing. So many questions will be there in the UL. I think 2 to 3 questions, and in NBME also they have asked question. If this is the hysteresis curve, अगर ऊपर जा रहा है, if the curve is going upward, it is obstructive lung disease. If the curve is going downward, think about restrictive lung disease. Just make it as simple as possible. Don't go for logic and explanation in all of the things. Okay, so just remember this. Hysteresis के ऊपर obstructive lung disease, hysteresis के नीचे restrictive lung disease. All right. Okay, moving forward. Pulmonary circulation. Okay, pulmonary circulation. You don't have to remember everything. Just this simple term. Pulmonary circulation is a low resistance, high compliance system. Low resistance, high compliance system. Okay. Hypoxic vasoconstriction that shifts blood away from the poorly ventilated regions of lung to well ventilated regions of lung. Okay. The decrease in atmospheric pressure causes hypoxic vasoconstriction that shifts the blood away from poorly ventilated region of the lung to well ventilated. So these 2 points are important. Okay. Now see, there will be two types: perfusion limited and diffusion limited. You don't have to understand what they are. You don't need to know anything. But if you want to be on a safer side, if you want your concept to be clear, refer VRS physiology. Okay. It is a small book. This small book for physiology, but they have explained everything and whatever is important for USMLE, and they also have few questions. So if you solve that questions and everything you read from that, you're good to go. So perfusion limited में क्या होगा? Perfusion limited में CO2 and N2O can be the example. Gas equilibrates early along the length of capillary. Okay, exchange can only increase if blood flow increase. Coming to diffusion limited, oxygen and carbon monoxide. Gas does not equilibrate by the time blood reaches the end of capillary. Okay, simple, but इतना ही याद रखो. All the example, that is CO2 and N2 and here O2 and CO. Okay, nothing else. Yeah, another important point: chronic hypoxic vasoconstriction may lead to pulmonary hypertension, that is called permanent. So diffusion, this formula याद रखनी है, and based on that you will be asked to say whether the pulmonary circulation is increasing or diffusion is increasing or decreasing. Okay, NEET में भी आता है ये. If the area of capillary is increased, if the pressure difference is increasing, if the all those stuff. So this is very important again. Okay, so just remember the formula and you are good to go. Pulmonary vascular resistance, ignore it. Don't focus on unnecessary information. Ignore it. Okay. Ventilation perfusion mismatch. Ventilation perfusion mismatch. What all needed to remember here is ventilation at the apex of the lung and VQ at the base of the lung. Okay, this is important. This is the first point. Second, both ventilation and perfusion are greater at the base of the lung than at the apex. With exercise, there is vasodilation of apical capillary. So V by Q ratio approaches 1. Okay, so this is second point. Third, V by Q is 0 if there is obstruction. Okay, and V by Q is infinity if there is a blood flow obstruction. Okay, here there will be shunt and here there will be blood flow obstruction. Okay, so see how they will be asking you over here is they will give you a case of foreign body aspiration. Okay, here they will be giving you a case of foreign body aspiration, and you need to remember whether it will be 0 or whether it will be infinity. Same thing over here. They will be giving you a case of pulmonary embolism and you need to know whether it will be 0 or infinity. So these are the things that you need to remember, and please uh, listen to my recommendation. BRS physiology is the best. They have given so many cases for this. So if you don't have the book, just take up the PDF and just read this part. Okay. Just give me a minute, Malia. Okay.
Okay.
Okay. मलिया जी, are you there?
Yes, yes.
सॉरी यार, मुझे एक इम्पोर्टेंट काम है, मुझे मेरा फ्लाइट बुक करना था, तो वो पेमेंट का इशू चल रहा
Okay.
था. ओके.
Okay.
या. ओके. ओके. So yeah, I was saying कि BRS physiology, just refer it. It's going to be very helpful for you. And yeah, another thing that they will be asking is this in zone 1, zone 2, and zone 3. You have to remember PA, PA, and PA. One is arterial, one is alveolar, and one is venous. Okay. So all this stuff, it's better कि आप you memorize it. Okay, it will be better if you memorize it, because in the exam you are not getting any chance to apply all the concepts. Okay, so all these things you need to memorize here in ventilation perfusion match mismatch. Okay, another thing, ignore this alveolar gas equation. Never the questions have been asked. Okay, questions have never been asked. So till here, VQ mismatch, pulmonary circulation, lung and chest recoil, ventilation, and here work of breathing, all these, and hysteresis. These all are very very important point. This point you should know by heart. Okay. Moving on to carbon dioxide transport, that is CO2 transport. Okay. So CO2 is transported from tissues to lungs in three forms: bicarbonate, carbaminohemoglobin, and dissolved CO2. Okay. Don't worry about anything. And here just one thing you need to remember, that the chloride ion will come into play. Okay, the chloride ion will come into play. And there is one phenomenon. मलिया जी, phenomenon का नाम बता सकते हो आप? Can you tell me the name of phenomenon? हम्म. बोलो बोलो.
No.
हार्लेन इफेक्ट.
Phenomenon. Yeah.
या
Yes. Hard.
phenomenon, या. आपको what did you hear?
Phenomenon.
Okay, phenomenon. Okay,
Okay, okay, okay.
phenomenon. Okay, no worry. So in lung, oxygenation of hemoglobin promotes the dissociation of H plus from hemoglobin. This shifts equilibrium towards CO2 formation. Therefore, CO2 is released from RBC, Halden effect, and this all occurs when there will be the exchange of chloride and all those stuff. No, don't worry. You don't have to remember the whole process. Just remember what is this. Okay. And your important point that you need to write it down is yeah, levels of gases in tissues and lungs. Okay, so write it down. This is not given anywhere. This is extra point that you need to write down. So in tissues there will be low O2, whereas in lung there will be high O2. Second, in tissues there will be increase in CO2, increase in H plus ions, whereas in lung decrease in CO2 and decrease in H plus ion. Okay, it favors O2 unloading. It favors O2 unloading, and this is because of Bohr effect. And here it favors O2 loading, and this is also because of Bohr effect. All right. So yeah, just write this down. Tissues and lung decrease in O2, increase in O2, increase in CO2, increase in H plus, whereas decrease in CO2, decrease in H plus, and next one is favors O2 unloading, and this favors O2 loading, both because of the Bohr effect. Now remember one thing, when you study Bohr effect and all those stuff in detail, this is very confusing. Okay, ये बहुत confusing है. So I would tell you, just remember the stuff that I am telling you, because I did nothing all this, and in the exam also they are not asking this question. What all questions they are asking is I have already told you. Okay, so ज़्यादा दिमाग मत लगाना. This will be a complete waste of time for you. Okay, so just remember what I am telling you. Just give a look at this diagram and just remember this. It teaches me what will happen, lungs me what will happen, because you will have given this question. Okay. Now let's coming to hypoxia and hypoxemia. Now these all are the new things that they have added here in the 2020 edition. It wasn't given. So let's just see what they have given over here. आपका कौन सा एडिशन है मलिया जी?
2022.
Oh, so it's new one only, same,
I
right?
have it.
Okay,
Yes.
okay, no worries, no worries. So see, let's just write it down over here. See this part. Just a minute. Increase A gradient, decrease A normal A gradient, and yeah, increase. There will be okay normal A gradient and increase normal A gradient. Okay, so yeah, ये याद रख लेना कि normal A gradient में what are the examples and increase A gradient में what are the examples. I'll tell you. It's little confusing over here. So much confusion is there over here. This new edition is not at all good. So just remember what I'm telling you. Normal AA gradient. If in the question it says high altitude, okay, or if it says hypoventilation. Now what all comes under hypoventilation? Under hypoventilation, there will be opioid use, obesity, hypoventilation syndrome. Obesity, hypoventilation syndrome. Okay. So if these two cases are being talked in the exam, then think that it is talking about the normal AA gradient. Okay. But if they are talking about the increased AA gradient, here are some examples. VQ mismatch, diffusion limitation. Okay. Example fibrosis. And the next one is right to left shunt. Okay. Just remember these examples and AA gradient questions will be a cakewalk for you. If you want, ignore this. They are so much confused in this new edition and it's not at all good. Okay? ये लिख लो, just write this down. Okay? Let's move ahead. Just remember these examples and you are good to go. Alright. Hemoglobin, the basic information is there. Ignore it. Oxygen content, ये सब, ignore it. They never ever ask it. So what they ask is over here. CO poisoning में hemoglobin concentration normal, SaO2 is decreased, saturated oxygen. This is I think atmosphere is oxygen, partial pressure of oxygen in atmosphere normal, and total O2 content decreased. So this table is very important, very very high yield. Okay, in anemia, hemoglobin decreases. This two will be normal, O2 decreases. Polycythemia, so many of red blood cells. So hemoglobin concentration will be increased and total O2 content increase. Cyanide toxicity, normal, 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 everything will be normal. Meat hemoglobinemia, normal. Decrease in saturated oxygen, normal, and decrease in O2 content. This table is very important. So many questions will be asked. Okay, just think about it. Anemia hai, RBCs will become, RBCs will be less, so oxygen will also be less. Okay, hemoglobin is also going to be less. That's it. Anemia has no role in atmospheric oxygen or saturated oxygen or anything. Same goes for the polycythemia. Okay, CO poisoning, hemoglobin पे कोई असर नहीं करेगा. Okay, it, it will decrease the saturated and it will decrease the total O2. This is going to be very tricky. Okay, in the exam you will be given one case. You have to identify what the case is talking about, and then you will be selecting this. Coming to the most important part of the physiology, where most of the questions reside, is oxyhemoglobin dissociation curve. Just remember the features of these factors. Okay, all those factors that they have given here. लो इन्होंने factors भी table में नहीं दिए. Very bad. Just write down. Okay, I'm making you write down. Left shift and right shift. In the left shift, there will be decrease in O2 unloading to tissue. In right shift, there is increase in O2 unloading to tissues. Okay, this is the first point. Second, there is decrease in H plus, there is increase in H plus. So if there is decrease in H plus, it means there is pH, increase in pH. If it is increase in H plus, there is decrease in pH. Okay, this is the basic thing. Third, decrease in PCO2, increase in PCO2. Fourth, decrease in 2,3-BPG, increase in 2,3-BPG. Fifth, decrease in temperature, increase in temperature. Sixth, increase in CO. There is now no role about CO over here. Seven, increase in meth hemoglobin and increase in HbF. Okay, ये है आपका left shift के लिए. Coming to the right one, in the right we have high altitude. Okay, just write this down. This is going to help you rather than reading the whole thing. Okay, and you need to remember the left shift and right shift, how it is occurring. Okay, few important points in this paragraph that you need to remember are, let's just see. Right shift in ODC reflect decrease in HB affinity for O2, increase in O2 unloading. Okay, whatever we have written in the table. Left shift in the ODC reflect increase in HB affinity for O2, decreasing O2 unloading at the. Okay. Now what else is there is? Yeah. ODC had a sigmoidal shape due to positive cooperative. This is important. ODC has sigmoidal shape due to positive cooperative, that is tetrameric HB molecule can bind 4 O2 molecules and has higher affinity for each subsequent O2 molecule bound. Okay, it means कि if this is one molecule of oxygen, then this whole structure has the more stronger affinity to bound another oxygen molecule that are coming together. Okay, this is what it means. So this is what the reason for the sigmoidal shape due to positive cooperative. Okay, another thing, myoglobin is monomeric and thus does not show positive cooperativity. Curve lacks sigmoidal appearance. So this table is very important, and this small paragraph over here is very important. And believe me, this question is definitely going to be asked in your exam. In this two, in this whole page, this table and this oxygen hemoglobin dissociation curve. This is for sure going to be asked. Okay, so just note this down.
What's the fifth point over there? What's increasing and decreasing? They are not mentioned.
इसमें ना decrease in O2 unloading to tissue, and here increase in O2 unloading to tissue. Okay,
Uh, Fifth वाला only.
ये ना यही वाला ना
No, no, fifth वाला.
fifth वाला. Okay,
Not
fifth
first
वाला
one.
is. Okay, fifth one is decrease in temperature, and
Temperature.
here increase in temperature. Okay, the table and this table. If you are not able to remember, print out, निकालो, चिपका दो. Okay. So see, I have told you what else you need to remember here is respiratory physiology, and this will be going like this is going to be very easy for you rather than just going through all the concepts. But in spite of this, I would request you to refer BRS. I'm telling you this again and again because it will improve. It will improve your score somewhere or the other. Okay, now this is another very high yield, this entire page. So mark it properly. Response to high altitude. Okay, in the question, the case will be you went for trekking. How will your respiratory system adapt? Okay, or what will be the changes? So this is where you come. First, decrease in atmospheric oxygen, increase in ventilation, decrease in PaCO2, there will be respiratory alkalosis, and this what causes altitude sickness. And what is altitude sickness is headaches, nausea, fatigue, lightheadedness, sleep disturbances. So another type of case that they can ask is tracker comes to you with these symptoms. Okay, so these are the two type of case that they will be asking you, and later in the question they will be asking you about the parameters. Okay, they will be asking you about the parameters. So parameters may these all are what I told you: decrease in PiO2, increase in ventilation, decrease in PaCO2. Okay, chronic increase in ventilation. Another increase in erythropoietin, increase in hematocrit and hemoglobin due to chronic hypoxia. Okay, ऑक्सीजन नहीं मिल रहा है तो बॉडी इज ट्राइंग टू अडेप्ट इट बाय producing more and more RBCs and more oxygen affinity. Increase in 2,3 BPG binds to hemoglobin. So rightward shift of Xc hemoglobin disease curve. So increase in O2 release. Okay. So as we have seen over there, high altitude may it shift towards the right. Cellular changes means increase in mitochondria. Body will require more energy. The cell will require more energy. And from where the energy comes? Mitochondria. Increase in renal excretion of bicarbonate to compensate for the respiratory alkalosis. Okay. Chronic hypoxic pulmonary vasoconstriction, increase in pulmonary vascular resistance, increase in pulmonary hypertension, and that will ultimately lead to the right heart failure, right ventricular hypertrophy. So all these points are very important and questions have been asked repeatedly. So everything is important over here. Moving to second case, response to exercise. Same, same case will be there. A person who exercises daily in the last few months, what will be changes in parameters of respiration. Okay, simple case will be coming to you and then they will be testing your parameters. Okay, so increase in heart rate and stroke volume, more exercise, more oxygen requirement by the body, so heart has to pump more, stroke volume will be more. Okay, increase in pulmonary blood flow, and as a result there will be increase in VQ ratio from base to effect. Okay, increase in cellular respiration, so increase in CO2 production. Okay, right shift of ODC. Okay, increase in increase in respiratory rate to meet the increase in O2 demand. Okay, PaO2 and PaCO2 are maintained, they will be normal, no changes in PaO2 and PaCO2. They will ask you what are the changes in level of PaO2 and PaCO2. You have to write normal. Okay, you have to select normal one. Decrease in PbO2 due to O2 consumption, increase in PbCO2 due to CO2 production. Right, this is very important. सब में question आया. There is question asked from all of them. Okay, so these two very important. Moving to meth hemoglobin. Meth hemoglobin, what they have asked is iron in hemoglobin is normally in reduced state, that is ferrous Fe2 plus state. Oxidized form of hemoglobin does not bind to O2 as readily as Fe2 plus state. Okay, but has increase in affinity for cyanide. So it causes tissue hypoxia. Okay, and as a result, it will decrease the O2. This Fe3 plus is known as methemoglobinemia. That's it. That's it. They are going to ask. And another thing that they will ask here is dapsone, a local anesthetic, and nitrites cause poisoning by oxidizing Fe2 plus to Fe3 plus. So in the question they gave you that the person is undertaking a dapsone drug or is consuming lots of nitrite. Okay, so you have to look for that. अब nitrite किस में आएगा? Most commonly it will be coming from smoky dishes like fish. Okay, lots and lots of consumption of fish can cause increase in nitrate production, or from dietary intake or polluted water sources. So everything comes under here. Okay. Methemoglobinia can be treated with methylene blue and vitamins. Okay, this is the treatment. So in this page, each and every line I would suggest you highlight. Okay. Yeah, response to high altitude and response to exercise. I hope you must have seen the questions on UL, and so many questions are there based on that. I think we are done with physiology now. Last topic remaining. Okay, I just quickly do this. Cyanide and carbon monoxide. Okay, see, both inhibit the aerobic metabolism via inhibition of complex 4 of ETC. Okay, that's it. It inhibits the complex 4 of ETC. You remember in biochemistry we did complex 4, that is carbon monoxide, was acting as an inhibitor. Okay, the same thing we are learning here. Now what will happen? The difference between cyanide and carbon monoxide poisoning. Amygdalin ingestion, that is found in apricot seed, synthetic product combustion, cyanide ingestion, that is in the suicide attempt, mostly in the suicide attempt. Whereas carbon monoxide is gas heaters. In this, there will be case um, you went to winter farmhouse, you went to winter farmhouse, and there were heaters, old generation heaters. Okay, so whole generation heaters, they cause a lot and lot of carbon monoxide poisoning. Okay, presentation: headache, dyspnea, drowsiness, seizure, coma. Must have cherry red skin. Cherry red skin is important. Breath may have almond odor. But cherry red skin is very important. Here, headache, vomiting, confusion, visual disturbances, coma, may have cherry red skin with bullous skin lesion. Okay, bullous skin lesions and cherry red skin. And here, as I told you, see, when you go to a winter farmhouse, you will be going with your entire family, right? So here, the problem will be the symptoms will be seen in all the family members, not only you. Okay, but here, individual symptoms can be seen because you might be consuming that by your own, or by the fruit, or by the suicide attempt. Okay, labs: normal PaO2, elevated lactate, anion gap metabolic acidosis. Here, elevated carboxyhemoglobin. Okay, not lactate. Another important thing, classically associated with bilateral globus pallidus lesions. Bilateral globus pallidus lesions on MRI. See, these are bilateral globus pallidus lesions. Effect on ODC, normal. There will be left shift over here. We wrote CO poisoning, left shift. Okay. Treatment: decontamination. They don't ask about the treatment, so it's okay. Ignore it. But this all stuff important. Cyanide and carbon monoxide poisoning, you should be able to differentiate. Okay. So with this, we finish our physiology part. I took a long time because there was some important task in the between. But now we have finished the physiology, and now we'll move to pathology. Okay. So all this stuff that we have marked in physiology, they are very important. The stuff that I have omitted, you can leave that. Okay, leave that. NBME don't won't have many questions, and the exam they also won't ask many tough questions like this. Okay, let's start with the pathology now. Maliaji, any doubt in the physiology part? Anything you want to ask?
No, no.
Okay, so you are solving UL. I hope
Yes.
काफी questions देखे होंगे आपने ऐसे.
Yes, yes, yes.
Okay, so I think now there is a clear image about it. क्या क्या करना है, क्या क्या नहीं
Yes.
करना है. Okay, all right. Moving on to the pathology part. Rhinocyanitis. It is a part of ENT. Never the questions have been come, but let's just see for the safer purpose. Just a small topic. Obstruction of sinus drainage into nasal cavity. Okay. Inflammation and pain over the affected area. Typically affect the maxillary sinus. Okay. So this is all we that study in the maxillary region in ENT. Okay. They haven't asked the question till now, but you can see. Just remember this part: superior meatus, middle meatus, and inferior meatus. Where does they drain into? Okay, so this you need to remember. It drains into posterior ethmoid, into frontal maxillary and anterior ethmoid, and drains into nasolacrimal duct. This is important. Okay, even in NEET PG they ask questions like this, so it's okay to remember here also. Some of the microbes that they cause are viruses, that is rhinovirus. Bacterial infection can be superimposed with a rhinovirus, that is Haemophilus influenza, strep pneumo, and Moraxella catarrhalis. Okay, that's it. That's it. Not very important. So just give a read. But here you remember one thing, this, because this is a part of anatomy. Superior meatus, middle meatus, and inferior meatus. This is a part of anatomy. So remember this. Coming to epistaxis. This is again important, but not so important. Again, this is a part of ENT. Nosebleed most commonly occurs in the anterior segment of nostrils. Life-threatening occurs in the posterior segment, sphenopalatine artery. This is important question that they have asked. And this Kesselbeck's Dreiberg's leg, this plexus you need to remember. Kesselbeck's plexus. Okay, so what all arteries, arteries are there over here? This you need to remember. Okay, that's it. Head and neck cancer, mostly they are squamous cell carcinoma. Nothing else. Okay, nothing else you need to remember. Squamous cell carcinoma, move ahead. Deep venous thrombosis. So in deep venous thrombosis, this becomes important topic, and let's just see what they have given. So blood clot within a deep vein, okay, swelling and redness and warm. Predisposed by workout triad. Workout triad is very important. So what happens in workout triad? There is stasis, there is hypercoagulability, and endothelial damage. One simple case that they will give you is patient had a long haul flight, okay, like 22-hour flight. For example, you are going from Mumbai to New York, New York City. So it is a long flight, and if you are going in the economy class, you will be just sitting at one place, okay. बस वही सीट पे बैठे रहोगे, you will be sitting on that seat. So as a result, there occurs a stasis of blood flow, okay. As a result, there is stasis of blood flow, okay. So because of this stasis, there might be formation of clot, and this clot then might migrate from your legs, and it might go to your lung, and it may obstruct the breathing, and you might die. Okay, simple. So this is the most common case that they ask, and 99% they will give you this case only. Okay, so let's just see what all things are there. As I told you, most pulmonary emboli arise from proximal deep veins of lower extremity, iliac, femoral, and popliteal vein. D-dimer test may be used clinically to rule out DVT if disease probability is low or moderate. Imaging test of choice is ultrasound with Doppler. Ultrasound with Doppler. Use unfractionated heparin or low molecular weight heparin for prophylaxis and acute management. This is high. They will ask you this. Okay. And another thing is, one important point. It is not given over here, so that write it down. There is, Homan's sign. Homan's sign. What is this? Homan's sign is calf pain with dorsiflexion of foot. Okay, so Homan's sign is also seen here. Calf pain with dorsiflexion of foot. Okay, just write it down. All right, let's move ahead. Pulmonary emboli. I'll just say important, not high yield. The questions haven't been asked. So let's just see. Only one or two questions have been asked. Let's just see. Obstruction of pulmonary artery or its branches by foreign material, usually the thrombus that originated somewhere else. Okay. Affected alveoli are ventilated but not perfused. This is important line. Ventilation present, perfusion not present. Okay. May present with sudden onset dyspnea, pleuritic chest pain, tachypnea, tachycardia, hypoxemia, respiratory alkalosis. Large emboli or saddle emboli may cause sudden death due to clot, preventing the blood from filling left ventricle and increase right ventricle size, further compromising left ventricle filling, obstructive shock. So, pulmonary emboli is also one of the cause of obstructive shock. Moving ahead. CT pulmonary angiography is the imaging test of choice. ECG may show sinus tachycardia or less commonly S1Q3 T3 abnormality. You won't be asked to identify it, but they will give you in the question only. S1Q3 T3 they will give you in the question only. Okay. Next, lines of Jahn are interdigiting areas of pink platelets that are made of fibrin and RBC. Okay, so here there are lines of Jahn. Where is this? These are all lines of Jahn. Okay, lines of Jahn. So these are all lines of Jahn. What does lines of Jahn contain? Platelets, fibrin, and RBC. Okay, that's it. Treatment is anticoagulation. So there are three types of pulmonary embolism that you need to remember: fat, air, and amniotic. Fat associated with long bone fracture. So here it becomes a high yield because questions have been asked on fat emboli. They have given a case: patient who fractured his hand comes to you for dyspnea. Okay. Patient who fractured his hand 1 or 2 months back, he comes to you now for dyspnea. Straight away, our answer should go for fat emboli. Okay. Classic triad of hypoxemia, neurologic abnormalities, and petechial rash. Okay, but this history will be given. Patient who fractured his hand 2 months back now came to you for dyspnea. So you should straightly think about embolism. Air emboli. Nitrogen bubbles precipitating in ascending divers, so deep sea divers. Here they will give you the case of deep sea divers. And amniotic fluid emboli typically occurs during labor or postpartum but can be due to uterine trauma, can lead to DIC. Okay, so here how they will present you the case is amniotic fluid emboli may after birth or maybe during labor, mother feels breathlessness. Okay, mother feels breathlessness, her oxygen like oxygen saturation start dropping so fast that you don't know what is even happening. So this is what amniotic fluid embolism is. Within 2 minutes the mother can die if not taken care of. Okay, so breathlessness during the labor or after the delivery, just after the delivery. Okay, because just after the delivery there is lots of rupture of membrane, sometimes there is bleeding also. Okay, so the clot that is formed due to bleeding can enter the amniotic fluid cavity and it can lead and form emboli. So this is what amniotic fluid embolism is. So as I said, this is not very high yield, but these points are important to know. Okay, let's move to mediastinal masses. Again, not high yield, just important. Let's note this down. These two cases. All right. So here mediastinal masses, you can skip this. Mediastinitis, what you need to remember is inflammation of mediastinal tissues, commonly due to post-operative complications of cardiothoracic procedures less than equal to 14 days. Okay, if less than equal to 14 days may, if there are complications and there is something like chest pain occurring, you should go and think about mediastinitis. Okay, so here they have given the clinical features: fever, tachycardia, leukocytosis, chest pain, and sternal wound damage. Okay, it can also be due to some microbacteria. They are histoplasma capsulatum. Okay, histoplasma capsulatum, I think is a fungi. Okay, so histoplasma capsulatum. Yeah. Pneumomediastinum. Pneumomediastinum means presence of gas, usually air, in the mediastinum. Can either be spontaneous due to rupture of pulmonary valve or second due to trauma, iatrogenic or Biover syndrome. Okay. Ruptured alveoli allow tracking of air into the mediastinum via peribronchial and perivalvular sheath. Okay, leave this. But remember this, presence of gas, usually air in mediastinum. Okay, clinical features is chest pain, dyspnea, voice change, subcutaneous emphysema, positive Haman sign, crepitus on cardiac auscultation. So here now what will happen is they haven't given the X-ray. I think, yeah, they haven't given the CT over here. So what will happen in CT is, see, this is the lungs. Okay, this is your heart. This is your heart. Okay, so if you look properly now, if you look carefully, what happens in pneumomediastinum is there will be this blab. There will be a blab in the lung. Okay, so this blab is because of presence of air in the lung, and this is what known as pneumomediastinum. Okay, that's it. That's it for the mediastinal pathology, nothing else. Let's move ahead. Now coming to the main deal of the respiratory pathology, that is obstructive lung disease and restrictive lung disease. Before that, you must have seen the questions like this, so many questions like this. So just remember, if this is a normal, if it is going towards the left, it will be obstructive. It is going towards the right, it is restrictive. Just as simple. Okay, very simple. It's nice also, nothing else to remember. Alright, now let's look at the parameters over here. What happens in obstructive lung disease? FEV1 decreases, FVC decreases, so this ratio will decreases. Okay, rest all lung volume increases. Now opposite thing will happen over here. Lung volume decrease, FEV1 also decrease here, FVC also decrease here. But the problem here is FEV1 doesn't decrease in such great extent like obstructive. Okay, in obstructive it decreases so much, so overall ratio has to decrease. But in restrictive, it can be at a normal or it can be decreased. Okay, so based on these parameters, you can diagnose whether it is obstructive lung disease or it is restrictive lung disease. Let's just see obstructive lung disease first. As I told you, the parameters, all the lung volumes will increase, whereas FEV1 will decrease, FVC will decrease, and the ratio will decrease. Okay, and it leads to VQ mismatch. In the question, either you will be asked to identify the parameters, or either you will be asked to identify what type of disease it is, whether it is obstructive or it is restrictive. You won't be asked to do both. Okay. If they ask you about the parameters, then they will ask you about the arrow, decrease, increase, decrease, increase, all those stuff. Okay. So let's just see now different types of obstructive lung disease. All right. The first one, let's discuss about the emphysema. In the emphysema, you need to remember the barrel-shaped chest. Expiration is prolonged or to purse the lips. Okay, purse the lips. And because of this, the patients with emphysema are called pink puffers. Pursed lips, pink puffers. So they are known as pink puffers. Okay. So there are two types of emphysema. In actual, there are four types, but for the USMLE point of view, you just have to deal with the two types, centri-SNR and pan-SNR. How to distinguish? In one of the cases, they will be giving you smoking. Okay, so smoking frequently in upper lobe. So smoking say धुआ जाएगा. Smoking develops smoke. So smoke goes up. So most of the time it will be mostly in the upper lobe. Okay, because of smoking there will be centri-acinar emphysema and it will be affecting the upper lobe. See, they will spare the distal lobe. Okay, whereas in pan-acinar affect the respiratory bronchioles and alveoli, that is the distal alveoli, and it is associated with alpha 1 antitrypsin deficiency, frequently in lower lobe because there is no smoke. Whereas in centri-SNR, as because of smoking, the smoke is going up, it will be affecting the upper lobe. Okay, what is seen on chest X-ray? Increase in AP diameter, flattened diaphragm. Okay, so nothing else. You can avoid this. They won't ask you about this, but they will definitely ask you about this part. Centri-SNR or pan-SNR. Now moving on to the physiology, pathophysiology. Okay, moving on to the pathophysiology, what they will have over here is enlargement of air spaces, Decrease in recoil, increase in compliance. Okay, decrease in recoil, increase in compliance. Okay, so compliance will be so much in now it becomes difficult for the lung to carry out the normal process. इतना सारा हवा भर के रखा है but gas exchange नहीं हो रहा. Okay, decrease in DLCO from destruction of alveolar walls, imbalance of proteases and antiproteases, it will lead to increase in elastase, so there will be decrease in elasticity. Okay, decrease in elasticity and increase in compliance, this is what you need to remember in terms of pathophysiology. So that's all for emphysema. This part is very important for emphysema. Okay, so just note properly, centriacina and penacina, if it is smoking, smoke will go up, so upper lobe will be affected, whereas in penacina there is no smoking, so lower lobe will be affected. Okay, compliance will be increased, elasticity will be decreased. That's it. Let's move to the chronic bronchitis. Chronic bronchitis are also known as blue bloaters. Okay, chronic bronchitis patients are known as blue bloaters. So presentation will be wheezing, crackles, cyanosis, polycythemia, and all those stuff. The wheezing is a typical sound like whistling in the lung. The sound will be like this. So it might you might get in the exam, you might be asked to listen to the lung sound. So if there is a whistling sound, it means the wheezing. And whistling sound is seen in two pathology, one in asthma and second in chronic bronchitis. Okay, so pathology, what, let's see the pathology. Hypertrophy and hyperplasia of mucus secreting glands in bronchi. So mucus concentration increase over here, so much of mucus over here. Okay, Reid index, that is thickness of mucosal gland layer to the thickness of wall between epithelium and cartilage. This is 50 degrees. This is important. They will ask you what is Reid index. Okay, directly they will ask you what is Reid index. So in that you will be selecting this option. Okay. Now diagnostic criteria. Productive cough for greater than 3 equal to or greater than 3 months in a year for greater than 2 consecutive years. Okay. DLCO will be normal in chronic bronchitis, whereas DLCO decreases in emphysema. Okay, DLCO decreases in emphysema. DLCO is normal in chronic bronchitis. Okay, so this is how you will be distinguishing. Blue bloaters, pink puffers. Increase in mucus, there can be either centri or panacinal. Increase in compliance of lung. Okay, so this is how you will be distinguishing emphysema and bronchitis. Moving on to the asthma, the most commonly asked question. Intermittent episodes of coughing, wheezing, tachypnea, dyspnea, decrease in inspiratory-expiratory ratio, mucus plugging. Severe attacks may lead to pulsus paradoxus and triggered by viral upper respiratory tract infection, allergen. Most commonly by allergen. It is type 1 hypersensitivity reaction. Okay, so asthma and chronic bronchitis presentation will be mostly same. There will be wheezing, there will be whistling sound in the lung. Okay, coming to second, hyperresponsive bronchi, reversible bronchoconstriction. This term, if you get, straight away go for asthma. Reversible bronchoconstriction. Okay, smooth muscle hypertrophy and hyperplasia. Now another thing over here is Kurtzman spirals. What are Kurtzman spirals? Shed epithelium forms gold mucus plug and charcot-laden crystals. Eosinophilic hexagonal double-pointed crystals formed from the breakdown of eosinophils in the sputum. So they will ask you what are these? Charcot-laden, and they will ask you Kurtzman spiral. So you should know whatever is given in the bracket part. Okay. The DLCO can be normal or increased. Just a minute. All right. So DLCO can be normal or it can be increased. Now, as I told you, asthma can be type 1 hypersensitivity reaction. So here, how we can be diagnosing it? Diagnosing can be done by either spirometry. Okay. And this spirometry you won't be asked in the exam. Okay. So it's not important over here. What is important over here is we diagnose it by the drug, that is methacholine drug. Okay. So methacholine is important. Second, NSAID exacerbated respiratory disease. So sometimes the asthma is caused by NSAID too. Okay, like if you are having body pain, or if you are having some type of sore pain in the muscle, so sometimes you will be taking NSAID, that is a painkiller. Okay, so most common painkiller that you will be taking is aspirin. Okay, the most common is aspirin. Okay, and it's a, what will aspirin do is there will be airway constriction, chronic sinusitis with nasal polyp. Now there will be one case for you. If you are doing snowboarding, okay, you are doing snowboarding, mostly they will give you the case of snowboarding only. Okay, and uh, after a whole day of snowboarding, you feel pain in the leg. So what you will do? You will take a painkiller. Okay, but the painkiller can be anything. In practical life, it can be ibuprofen, it can be anything. But here, what the USMLE focus on is aspirin. Okay, after taking aspirin, the next day you come with these symptoms, breathlessness and all those stuff. Okay, so this is what occurring. So this is what it causes. If you take aspirin, then aspirin is going to cause airway constriction, chronic sinusitis, so much of sinus problem. You will be sneezing continuously, and the most important one is nasal polyp. There will be polyps in the nose. Okay, so this is what is known as uh, aspirin-induced asthma, and it goes by the term Samter's triad. Okay, Samter's triad is associated with aspirin. So make sure whenever you hear the term nasal polyp in the asthma, think that the patient has took aspirin. Okay. Another thing is, which drug is used to diagnose asthma? Methacholine. Type 1 hypersensitivity reaction, and the year Kurtzman spirals and Charcot Leyden crystals. So all these are the important points. And last point, reversible bronchoconstriction. All these are very important. Okay, so these are the images that you need to be worrying about. These are Kurtzman spirals and these are Charcot Leyden crystals. You should be able to identify them. Okay, that's it for the asthma. Moving on to bronchiectasis. Bronchiectasis we have discussed earlier. The most significant feature of bronchiectasis is the foul smelling sputum, frothy sputum. Okay, to purulent sputum. What happens here is there will be dilated airways in all bronchitis, in emphysema, in asthma. There was bronchoconstriction. The airways were constricting, whereas in bronchiectasis there is dilatation of airways. So this is how you will be distinguishing. In the question, they will give you purulent sputum, and another thing that they will be giving you is dilated airways. They will give you. Okay, so let's just see what they are associated with. Bronchial obstruction, poor ciliary motility. We have done the Cartagena syndrome. Okay, along with the cystic fibrosis, we did Cartagena syndrome. Okay, so we are not discussing it again over here. So that's it. That's it for the obstructive lung disease. Now, one more thing. If we are studying obstructive lung disease, make sure bronchiectasis is not involved in obstructive lung disease. Okay, bronchiectasis obstructive lung disease में नहीं आएगा. Bronchitis, emphysema, and asthma. Okay, so that's it. We are done with the obstructive lung disease. Okay. Let's move on to the restrictive lung disease. Alright, restrictive lung disease. So, as we know the parameters for a restrictive lung disease, the lung volume will decrease, and FBC, this ratio, either it can be normal or it can be increased, but it won't be decreased. Okay, why it won't be decreased? Because FEV1 is not so much decreased. Okay, FBC is decreased more than FEV1, so either it can be increased this ratio or it can be decreased. Okay, moving ahead. There can be two mechanisms for restrictive lung disease. Either it can be altered respiratory mechanics. Second one is diffuse parenchymal lung disease, also called the interstitial lung disease. Okay. All. So in the altered respiratory mechanism, you have this viral disease. Okay, polio, myasthenia gravis, Guillain-Barré syndrome. Okay. All right. Now moving on to parenchymal lung disease, that are interstitial lung disease. Okay, the most questions will be asked on interstitial lung disease. Now see, one important point that we ignored over here is this bracket part. Okay, so here if there is an altered respiratory problem, respiratory mechanic, some viral disease is there, or your lungs are not able to perform the respiration, then DLCO will be normal and AA gradient will be normal. But if there is some disease occurring in your lung, that is ILD, then DLCO will be decreasing and A gradient will be increasing. This is very high yield. They will be asking you with the arrow form. Okay. So in respiratory pathology, there is nothing new. All those that I've given in the first aid, nothing will come from this outside of this. Okay. So make sure your first aid is very strong in case of respiratory disease. Okay. So what all comes under restrictive lung disease? Pneumoconiosis we will be discussing next. Sarcoidosis we will be discussing next. Idiopathic pulmonary fibrosis we'll be discussing here only. Okay. So they haven't given here. They have given down. Let's just discuss it together. Progressive fibrotic lung disease of unknown etiology may involve multiple cycles of lung injury, inflammation, and fibrosis associated with cigarette smoking, environmental pollutants, and genetic defect. Okay. तो findings क्या होंगे? Progressive dyspnea, fatigue, non-productive cough, crackles, clubbing. Okay, clubbing means your fingers, digital clubbing. The fingers will become very fat. Okay, imaging will show peripheral reticular opacities with traction bronchiectasis. This is very important. Traction bronchiectasis is very important. Traction, the word traction is very important in restrictive lung disease. To make it high yield, traction is very important. Honeycomb appearance of lung. Honeycomb appearance of lung, wherever you see, think about idiopathic pulmonary fibrosis directly. Don't ever read anything else. Honeycomb lung pattern, idiopathic pulmonary fibrosis. Okay, that's it. That's it. You need to remember. The case will be given to here is patient comes to you again and again. Okay, or the patient can give history of radiation. Okay, like so many chest x-rays, so many uh, MRIs and all those stuffs have been taken from his body, and because of the radiation, fibrosis occurred in the lungs, and this is what caused idiopathic pulmonary fibrosis. Okay, that's it for IPF. We are done with IPF. Granulomatous with pollenzitis we will do in CVS. Eosinophilic granula we will do in hematology. Drug toxicity, yeah. So these drugs are pretty important. These are all the anti-tumor drugs that cause lung problem. Okay, so this you need to remember. ARDS will be doing later. Radiation induced lung injury. It is similar to the idiopathic pulmonary fibrosis. Okay, simple. Just here, one thing you need to remember is this mediators IL-1, IL-6, TNF. That's it. Okay, so these are the examples of restrictive lung disease. We'll be doing these examples one by one now. Hypersensitivity pneumonitis. This is another case. This is also very important. The question will be asked for sure. Here the case will be uh, dyspnea in farmer. Dyspnea in farmer. Write this down. Dyspnea in farmer. Now what happens here is it is a type 3, type 4 hypersensitivity reaction due to environmental antigen. Okay. Often seen in farmers and bird fanciers. Acutely causes dyspnea, cough, chest and fever, headache, everything. Self-limiting. It means it resolves on its own. Resolves on its own. Okay, so case will be given to you a person, a patient who is a farmer, and because of the environmental allergens or antigens, he is not able to breathe properly and headache and all those stuff. But he says कि it resolves after 2 days. कि 2-3 दिन में ठीक हो जाता है. Okay, the case will be like this. Okay, so there will be irreversible fibrosis with non-caseating granuloma. That's it. And another important point is alveolar septal thickening. Traction bronchiectasis. Traction is very important. I am repeating again. Traction is very important when you are dealing with restrictive lung disease. Okay. So we are done with two types of restrictive lung disease. We will do 2-3 more types of restrictive lung disease. Hmm. Sarcoidosis. So sarcoidosis is characterized by immune-mediated, widespread non-caseating granuloma. Here, non-caseating granuloma is important. We discuss in general pathology non-caseating granuloma. Okay, elevated serum ACE levels. ACE levels will be increased. These are all the diagnostic features of sarcoidosis. Elevated CD4 CD8 ratio. They will give you this in the question, or they will be asked in the option. CXR shows bilateral adenopathy and coarse reticular opacity. Bilateral adenopathy, if this is a lung, okay, this is a trachea, heart, everything. So bilateral adenopathy, they will be given like this. Okay, the moment you see this, straight away go for sarcoidosis. Okay, all other important points are associated with Bell's palsy, non-caseating granuloma, lupus pernio, that is skin lesions on face resembling lupus, interstitial fibrosis, as we studied, is a type of restrictive lung disease, erythema nodosum, rheumatoid arthritis like arthropathy, hypercalcemia is important, increase in calcium. Okay, and another thing is ocular uveitis, vitamin D activation due to increase in 1 alpha hydroxylase in macrophage. This is another important. Increase in 1 alpha hydroxylase in macrophages. This is very important. Okay, so all these points, one question has been asked based on all these points in your. Okay, and sarcoidosis for sure is going to come. Mark it at very very high. Okay, see, lungs के पास ही there is so much of adenopathy. Here also lungs के पास there is so much of adenopathy. Okay, this is a non-caseating granuloma. So all this is very important. Okay, and sometimes you might get confused. It is a type of restrictive lung disease. So FEV1 by FVC ratio is either increased or normal, and rest on lung volume, the TLC, RV, all those stuff is going to decrease. So don't forget, sarcoidosis is a restrictive lung disease. Okay, very very high yield. For sure, one question is going to come. Next, inhalation injury and sequelae. You can ignore this. No questions have been asked. Nothing. Moving ahead, pneumoconiosis, again, very, very high yield. One question definitely going to come. Okay, so here, asbestosis is from the roof but affect the base. Rest all will affect the roof. Silica, coal, berries, these are found from the crust of the earth. Okay, so they will be affecting the upper part, whereas asbestosis is found in the roof and it will be affecting the base part. It is opposite. Okay, so make sure you know that. First one, asbestosis. Asbestos causes asbestosis, that is pulmonary fibrosis. This is all we are discussing about a restrictive lung disease. So remember the parameters. Associated with shipbuilding is important, roofing is important, and plumbing is important. Ivory white calcified is important. Pleural plaques are important. So this all those one word. In the case, they will directly give you a patient was working in a shipbuilding industry. Patient was working in a roofing industry. A patient is a plumber. Okay, directly they will give you the case and you have to figure it out. Okay, it affects the lower lobe. Ferruginous bodies are golden brown fusiform rods resembling dumbbells, chimbal dumbbells. Okay, and that's it. I want to say, yeah, another thing. Risk of bronchogenic carcinoma is greater than the risk of mesothelioma. This is a very important point. Risk of Kaplan syndrome, that is rheumatoid arthritis and pneumoconiosis. If asbestosis occurs with rheumatoid arthritis, then it is Kaplan syndrome. Okay, or not only asbestosis, any type of pneumoconiosis. Okay, any type. If it occurs with rheumatoid arthritis, it is known as Kaplan syndrome. Coming back to our topic, asbestosis related disease. Four things you need to remember: shipbuilding, roofing and plumbing, lower lobe, bronchogenic carcinoma greater than mesothelioma, golden brown fusiform rods, and the last one is calcified plates. Okay, so let's see the image. See, these are the calcified plates. Okay, and these are the fusiform rods and calcified plates. Okay, so this is what you need to remember. Coming to berry losses, in berry losses also you need to remember exposure to beryllium in aerospace and manufacturing industry. The patient will be working in the aerospace, aeroplane manufacturing industry, or working in NASA. They might give you NASA. Okay. It affects the upper lobe. Simple. Okay. Coal workers pneumoconiosis. Prolonged coal dust exposure. Okay. So coal industry. Okay. Directly coal mining industry. So here what is important is it affects the upper lobe and there will be anthracosis, asymptomatic condition found in many urban exposed to sooty air. So lungs will be black and dark. Okay. Silicosis associated with sandblasting, foundries and mines. Again, occupation is very important in pneumoconiosis. Just write it down. Occupation is very important. If you figure out what occupation is there in what pneumoconiosis, you don't need to read out the full question. Straight away go for the answer. Okay. So in silicosis, sandblasting, foundries and mines, macrophages respond to silica and release fibrogenic factors leading to fibrosis. So here macrophages is important. Okay. It is thought that silica may disturb the phagolysosomes and impair macrophages. Okay. And this in turn leads to increase in tuberculosis. This is very important point. Tuberculosis risk increase in silicosis. Okay. Again, it is going to affect the upper lobe, axial calcification of hyaline. Okay. So these are the four types of pneumoconiosis that you are going to learn. And if you are thorough with the occupation, no need to read out the other question. Okay. Moving down to mesothelioma, malignancy of pleura associated with asbestosis. Okay, we have done this over here. Bronchogenic carcinoma, mesothelioma. Okay, one important point here is pleural thickening. So in the question, they might not highlight you the thickening of pleura or pleural thickening. They will just give you normally. You have to pick it out if pleural thickening is given or not. If pleural thickening is given, mesothelioma is the answer. Another important point that they will give you is that the tumor will be calratine and cytokeratin positive. Calratine and cytokeratin positive. Another important thing, tobacco smoking is not a risk factor. Smoking is not going to cause mesothelioma. Okay, that's it. That's it for pneumoconiosis. All right. Another one is ARDS. Let's take a 2 minutes break. मलिया जी, all clear? सब समझ आ रहा है?
Yes, yes.
एक दो तीन चार पाँच छः सात. All right, let's continue. ARDS. ARDS is another type of restrictive lung disease. Okay, let's just see. Alveolar insult. See, in here, this pathophysiology is very important. ARDS is also high yield. Release of pro-inflammatory cytokines, neutrophil recruitment, activation and release of toxic mediators, capillary endothelial damage and increase in vascular permeability, leakage of protein-rich fluid, formation of intraalveolar membrane. So they will ask how intraalveolar membrane is formed. Okay, they will ask how intraalveolar membrane is formed. So this is all the pathophysiology is important over here. Okay, and this is a non-cardiogenic pulmonary edema. There will be non-cardiogenic pulmonary edema. Okay, it means there will be no cardiac problem. Okay, no non-cardiogenic pulmonary edema. Decrease in compliance, vacuum mismatch, hypoxic vasoconstriction, increase in pulmonary vessel. So this is all the basic pathophysiology that you will be seeing. Okay, all right. Causes: sepsis, aspiration pneumonia, trauma, and pancreatitis. Okay, diagnosis. How you will diagnose? Abnormal chest X-ray, bilateral lung opacity. See, it is going to be so hazy. Okay, dua dua. Okay, so much of opacity you are seeing in the lung. Respiratory failure within 1 week of alveolar insult. Decreased PaO2 slash FiO2. Hypoxemia due to, they won't give you this. They won't even give you this. They will give you bilateral lung opacities, and symptoms of respiratory failure are not due to heart problem. Simple. Okay. So these 2 points are very important. Bilateral lung opacity and respiratory failure not due to heart problem. Okay. Consequences: there will be impaired gas exchange, compliance, and pulmonary hypertension management. Treat the underlying cause. Okay, PEP, positive expiratory pressure. So in ARDS, what you need to remember was main focus on pathophysiology, and this diagnosis was there will be no heart problem and bilateral obesity. That's it. Okay, done with ARDS. Now in sleep apnea and all those, you can avoid this entire thing, but only one thing is responsible over here. One thing is that you need to do over here is obstructive sleep apnea. Okay, so simple one case will be there. Patient snores a lot while sleeping. Okay, patient snores a lot while sleeping, and this is what obstructive sleep apnea. Okay, simple. Rest all just ignore it. They are not going to ask into detail over this topic. Okay, moving ahead. Pulmonary hypertension. Yes, pulmonary hypertension is another important thing. So many points you have to add over here. That was in NBME and UVL. Just wait. Let me see where I have written the point. Yeah. Pulmonary hypertension, pulmonary hypertension. Okay. First, let's just see what is given in the first step. Elevated mean pulmonary artery pressure greater than 20 mmHg at rest results in arteriosclerosis, medial hypertrophy, intimal fibrosis of all this stuff you already know. So, right heart failure. So, pulmonary arterial hypertension is very important. And in this, the first point we need to see pulmonary arterial hypertension, often idiopathic, females में ज़्यादा, heritable due to this gene mutation BMPR2. Okay. Now, what this BMPR2 does is inhibits vascular smooth muscle proliferation normally. Okay, normally it inhibits vascular smooth muscle proliferation. If this gene is inhibited, there will be so much of vascular proliferation. Okay, so this is important. They have asked one question in UWorld. Okay, and pulmonary vascular endothelial dysfunction results in increase in vasoconstrictor, that is endothelin, and decrease in vasodilator. This is another question that they have asked in UWorld. Okay, now what? Now how NBME is going to ask? How NBME is going to ask? Write down the case. shortness of breath plus non-productive cough, shortness of breath plus non-productive cough plus history of dysphagia, and next one is hands turning white when exposed to cold. So मलिया जी कुछ डायग्नोस कर सकते हो इसमें से आप? कैन यू डायग्नोस? इट इज अ पार्ट ऑफ मस्कुलोस्केलेटल सिस्टम. ट्राई करो. मस्कुलोस्केलेटल सिस्टम में है ये. मुझे ये बताओ व्हाट डज दिस मीन? हैंड्स टर्निंग वाइट व्हेन एक्सपोज टू कोल्ड. इसका मतलब क्या? लगाओ लगाओ दिमाग लगाओ. नो आइडिया. ओके. दिस इज
Mm,
राइनॉट phenomenon. राइनॉट phenomenon.
yes, yes, yes.
है
Reynolds
ना. या
phenomenon in
या.
nervous system.
So Raynaud phenomenon along with dysphagia, along with shortness of breath. Do you remember CREST syndrome?
Yes.
Musculoskeletal में है. The on the page before we start dermatology.
Yes, yes.
Okay. तो CREST syndrome के साथ जो breathing problem is there, that is pulmonary arterial hypertension most commonly. Okay, NBME has asked this, so make sure you remember this. And another thing that they will give you when they want to ask about the pulmonary arterial hypertension is in the question they will give you dilation of proximal pulmonary artery, increase in pulmonary vasculature markings, increase in pulmonary vasculature markings, and loud P2. This is very important. Dilation of proximal pulmonary artery, increase in pulmonary vasculature markings, and loud P2. All this is how NBME is going to ask. Okay, so I'm just highlighting it for you so it becomes easier. Dilation of proximal pulmonary artery, increase in pulmonary vasculature marking, and loud P2. This is the line they will use while asking pulmonary arterial hypertension. Okay, so that's all. We are done with pulmonary arterial hypertension. Another thing that they will confuse with pulmonary arterial hypertension is what it is. Yeah, another thing that they will confuse you is instead of all these markings, they will give you pulmonary infiltrates. Okay, they will give you pulmonary infiltrate. So now what will be the answer? Now the answer will be pulmonary contusion. Okay, pulmonary contusion. It means some extra trauma was applied and as a result the lungs were damaged. That is what pulmonary contusion. So pulmonary infiltrates aya, so pulmonary contusion, and if this all it is given, pulmonary arterial hypertension. Keep it as simple as possible and BME has asked it. Okay, with this we are done with pulmonary hypertension. Moving on to physical findings of selected lung disease. So in this diagram, this table is very important. Okay, they will ask you about the breath sound. They will ask you whether it is hyper resonant or dull. Percussion is hyper resonant or dull. They will ask you about the fremitus, in which the fremitus is decreasing, fremitus is increasing. Okay, and tracheal deviation is not a big deal if you remember good, or else you can avoid this. But pneumothorax you should know towards the side of lesion, away from the side. So better you do. Okay, but this you should know. Okay, based on the percussion only you will be able to diagnose. Okay, so this is very high yield. This is how your questions will be solved. All right, moving ahead. Digital clubbing. We have seen digital clubbing. Okay, no need to do it now. I hope this is clear. Moving ahead, atelectasis. So in atelectasis is also another important topic. Not high yield, but we can say important. So how the questions are asked over here is alveolar collapse, right upper lobe collapse against mediastinum. Right upper, most common is right upper lobe collapse. So there are four types of atelectasis: obstructive, compressive, contraction, and adhesive. Obstructive में airway obstruction prevents new air from reaching the distal airway, so old air is resolved. So mostly common. See, in this atelectasis, na, you don't have to remember the mechanism. You just have to remember the examples and type. For example, in obstructive, foreign body and mucus plug. In compressive, space occupying lesion, pleural effusion. In contraction, scarring of lung parenchyma, sarcoidosis. Okay, and in adhesive, loss of surfactant, NRDS. That's it. Don't apply any brain. Just remember what is given in the bracket and type of atelectasis. Okay, we are done with atelectasis. Another very high yield question: pleural effusion. See, respiratory pathology is very easy, the most easiest system. Okay, you just have to pick out what is given in the question, and you are good to go. Okay. Excess accumulation of fluid between pleural layers, restricted lung expansion during inspiration. Okay, effusion है तो fluid accumulation तो होना ही है. This is a common thing. Okay, now see, in 2022 edition they have added this light criteria. In 2020 edition there wasn't any light criteria. Okay, so this is very important in order to diagnose it. Fluid is consistent with an exudate if pleural fluid protein serum is greater than 0.5, pleural fluid LDH serum LDH is greater than 0.6, pleural fluid LDH. See, this is very important. I am repeating again. This last one LDH wala, this is how you will be diagnosing whether it is exudate or whether it is transudate. Okay, pleural effusion can be exudate or it can be transudate, and based on this you will be diagnosing whether it is exudate or transudate. So here there are some characteristics of exudate and transudate. Let's just see. Cloudy fluid, clear fluid. Exudate can be due to infection, malignancy, connective tissue disease, or lymphatic. Okay, whereas transudate is due to increase in hydrostatic pressure, that is heart problem, or decrease in oncolytic pressure, that is kidney problem and liver problem. Okay, so easily identify. And exudate often requires damage due to increase in risk of infection. अगर infection है, cancer है, then think about exudate. Whereas if there is heart problem, liver problem, kidney problem, think about transudate. Okay, and you know how to distinguish. LDH should be pleural fluid LDH should be greater than 2/3 of this one, serum LDH. Okay, this is how you will be distinguishing transudate and exudate. Very easy, nothing to confuse over here. Okay, moving ahead. Pneumothorax, another important high yield point. Accumulation of air in the pleural space. Effusion was fluid in the pleural space. Pneumothorax is air in the pleural space. Dyspnea, uneven chest expansion, chest space, decrease in tactile parameters, hyperresonance. So this is all that we saw in the table. Just remember that and you are able to diagnose. Let's just see the different types of pneumothorax that you need to remember. Primary spontaneous pneumothorax due to rupture of apical subpleural bleb arches. This is important. Occurs more frequently in tall, thin, young females associated with tobacco form. So case will be a male who is young, who is very tall, and he is a smoker. Okay, so this is the case for primary spontaneous pneumothorax. Secondary spontaneous pneumothorax, there will be some disease, emphysema or Marfan syndrome. Okay, simple. Traumatic pneumothorax caused by the blunt rib fracture, penetrating that is gunshot, or central line placement injury lung biopsy, injury, and all those stuff. So these examples will be given. You need to pick out the types of pneumothorax. And the last one, tension pneumothorax, can be from any of the above. Air enters the space but cannot exit. Increased trapped air causes tension pneumothorax. This is important. Okay. Trachea deviates away from the affected lung. May lead to increased intrathoracic pressure, mediastinal displacement, kinking of IVC. So as a result, there will be decrease in venous return. As a result, there will be decrease in cardiac output, and as a result, there will be obstructive shock, and as a result, there will be jugular venous distension. Needs immediate needle recompression and chest tube placement. See, everything is connected over here. Okay, so tension pneumothorax ka pathophysio is very important, and you must be knowing how to see the pneumothorax on the chest X-ray. See, this is the lung. Okay, this is the whole lung, but here it is collapsed. You can see this black space. Even here you can see this is the lung has been collapsed. So this space is empty, easily identifiable. Okay, that's all for pneumothorax. Moving ahead, pneumonia. Now, before beginning pneumonia, let's just first study the four stages of pneumonia, and then I'll give you a brief about different types of pneumonia. Okay, so how the pneumonia progresses is natural history of pneumonia. Congestion that occurs in 1 to 2 days, 3 to 4 days may red appetization, 5 to 7 may gray, and after 8 days there will be resolution. Okay, so let's just see what happens in congestion. Red purple partial consolidation, mostly bacterial exudate. Red appetization may there will be bacterial, but there will be RBCs, WBCs, everything. Gray may there will be no RBCs, there will be WBCs. And in resolution, enzymatic digestion by macrophages. It means they are going into the regenerative phase. Okay, so this is important, not high yield, but important. They might ask you. Okay, now moving on to this, our most important funda. Okay, but when you study in the university level, the pneumonia there can be lobar and another type is bronchopneumonia and all those stuff. In USMLE, they are not going to focus on that. Okay, in fact, what they are going to focus is if there is a lobar pneumonia, it involves entire lobe or the whole lung. So it is bronchopneumonia from bronchitis into a patchy distribution. Okay, so if this is a lobar, so this entire lobe is affected. If it is bronchopneumonia, it will be like this, bronchopneumonia. Simple. That's it. That's what you need to remember. Another thing. Now take a piece of paper and write down whatever I'm writing. Okay, whatever I'm writing, just write it down, and this is going to be very helpful for you guys. मलिया जी मैं क्वेश्चन पूछते जा रहा हूँ आपको, आप बताओ मुझे आंसर पता है कि नहीं फटाफट. ओके, देयर आर 20 क्वेश्चंस नाउ बेस्ड ऑन योर माइक्रोबायोलॉजी नॉलेज. फर्स्ट वन, bilateral lobar pneumonia in immunocompetent patient. कौन सा होगा बताओ, कौन सा माइक्रोब रिस्पॉन्सिबल होगा, क्विकली. नहीं आता कोई बात नहीं, फटाफट बोल दो.
In immunocompetent.
या इम्यूनोकॉम्पिटेंट.
Mm,
सोच लो आप, मैं दूसरा लिख लेता हूँ. Bilateral ground glass appearance. This so you might be knowing. Come on, it is a type of fungi. With age with pneumonia. Post post-influenza pneumonia. Influenza के बाद, after influenza. Fifth, pneumonia with
Strepto.
just a minute. Pneumonia with hyponatremia. Yeah. किसका आंसर आया?
Post-influenza pneumonia is streptococcal.
No, 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 no. पोस्ट इन्फ्लुएंजा हेमोफिलस इन्फ्लुएंजा में जो था. और
Um,
नो नो नॉट हेमोफिलस इन्फ्लुएंजा, इन्फ्लुएंजा वायरस. इन्फ्लुएंजा वायरस में कौन सा बैक्टीरिया वाज रिस्पांसिबल आफ्टर दैट वायरल इन्फेक्शन? कम ऑन. F or yes?
Staph.
F or yes? For immunocompetent patient, we have this mycoplasma.
Mm.
For ground glass fungi, we have pneumocystis jirovecii. सुना है नाम? Jirovecii सुना है
Yes.
ना? Okay, now tell me how to uh, diagnose pneumocystis jirovecii. What is the diagnosis we use? Bronchoalveolar lavage. Remember? Micro revise करो. For AIDS, we have streptococcus pneumoniae.
Yeah.
For hyponatremia, बताओ. Sketchy देखा है ना आपने? You saw the sketchy, right?
Mm. Yes.
Okay, tell me which bacteria was related to ships. वहाँ पे एक बड़ा सा स्टीमर था. कौन सा बैक्टीरिया?
Yes. Yes.
हम्म. ग्रे कलर का स्टीमर था. उसके नीचे एक बंदा मैप लेके खड़ा है. याद आ रहा है?
I remember the picture.
So what is the name? Come on, try to recollect what is the name. I can remember the name of sketch also. Come on. Legion of ships. Legion.
Yes.
Legionella. हाँ, लीजेनेला. ओके, ऐसे याद करना है. नेक्स्ट वन. ओके. 3 week old patient plus conjunctivitis. That was 2 weeks back.
Maybe for
Which? बोलो ये कौन सा है?
okay.
No.
Staphylococcus
No.
galacticus.
No. नो. 3 week old बोला है. डायरेक्ट बर्थ के बाद नहीं बोला है. गैलेक्टेसिया इज
Okay.
डायरेक्ट आफ्टर बर्थ.
Yes.
बोलो बोलो. चलो इसका स्केच याद कराता हूँ. पायरेट. पायरेट वाला शेप है. बताओ, पायरेट वाला शेप है. एक मरमेड भी है उसमें. बंदर भी है उसमें. बोलो बोलो बोलो. क्लेमाइडिया ट्रैकोमैटिस. क्लेमाइडिया. याद आया क्लेमाइडिया?
Hmm.
नहीं आया?
आ
कोई
गया.
बात नहीं. आ गया. ओके, मोर केसेस आर देयर. देयर आर 20 केसेस. अगर आपने 20 केसेस मास्टर कर दिए, योर न्यूमोनिया इज गोइंग टू बी बेस्ट. नाउ योर आंसर इज न्यूबॉर्न pneumonia in the first few days. Here it will be group B, Streptococcus galaxy. Okay.
Hmm.
Next, रैबिट के साथ हुआ तो बताओ. रैबिट्स वाला किया था ना? स्केच किया था रैबिट्स वाला?
Rabbits wala I don't remember. Rabbit.
क्यों? फ्रांसिस सेला ने किया था. फ्रांसिएला. This is not given in first aid, but it was extra. Rabbit. Then we have bird keepers.
Hmm.
बर्ड कीपर्स का भी सेम क्लेमाइडिया. चिट्टे की.
Yes.
वो चिट्टे के पैरट वाला आता है ना, वैसे ही उसका.
हाँ.
नेक्स्ट. ओके. साउथ वेस्टर्न यूनाइटेड स्टेट्स और अर्थक्वेक एरियाज. साउथ वेस्टर्न यूनाइटेड स्टेट्स और अर्थक्वेक एरियाज. कौन सा फंजाई? ये तो किया ही होगा.
सब किया है.
कॉकेई.
Cotton.
कॉकेडियड. कॉकेडियड समथिंग लाइक दैट. ओके, लिख लो फटाफट, लिख लो. और
Coccidiosis.
या कॉकेडियड. स्केच को आपने ठीक से रिवाइज नहीं किया है, स्केच रिवाइज करना
Hmm.
है। ओके, रिवाइज करते वक्त आंख बंद करो और स्केच को दिमाग में लाओ, क्या क्या था उसमें। ओनली देन यू विल रिमेम्बर इट फॉर लाइफ टाइम। लिख लिया, आगे बढ़े।
Yes.
ओके, तो यहाँ पे स्पेस है इसलिए यहाँ पे लिखते हैं 11th। ओके, डू यू नो स्टीपल साइन?
Hmm.
बोलो क्या होगा। 12th इज
People
एपिग्लोटाइटिस।
why
कोई ना, आराम से याद करो, कोई दिक्कत नहीं है। Then fever in farmer. Then air fluid level in CXR. It can be alcoholic or can be stroke. Then okay, in cattle farmer. Okay, another one. Nodular density seen in right upper lobe. तो स्टीपल साइन दिखता है कूप में। ओके, एंड दिस इज कॉज्ड बाय पैरामिक्सो वायरस। पैरामिक्सो वायरस है, हाँ ओके, देख लेंगे ये वापस, आई एम नॉट श्योर। पैरामिक्सो वायरस, एपिग्लोटाइटिस में हेमोफिलियस इन्फ्लुएंजा। हियर यू विल सी थंब प्रिंट साइन। ओके, हियर you will see that the kid is in tripod position. Fever in farmer, hypersensitivity pneumonitis. Air fluid level in chest X-ray. This is abscess, lung abscess. Cattle farmer में pneumonia. It is Coxiella burnetii. Nodular density seen in right upper lobe. It is aspergilloma. Okay, लिख लो ये सब. Just write it here only so that when you revise it becomes easier for you. All right. One important thing over here was,
Oh, wait a second.
हाँ ये लो हो गया,
2 seconds.
हो गया ना।
No, no, last 2 points.
ओके 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 ओके, लिखो लिखो। Nobody came today, everyone is, सब बच गए आज। ना सबको ये पूछता ना सबको मजा आता।
Done.
Okay, so let's move ahead. One important point that you need to remember here is yeah, cryptogenic organizing pneumonia. Here the symptoms will be of pneumonia, but the sputum will be negative for culture. Okay, and not to antibiotic. The patient will be treated by glucocorticoids but not by antibiotic. If this is the case, then this COP, that is cryptogenic organizing pneumonia. And another thing is bronchiolitis obliterans organizing pneumonia, BOOP. What is this? Is BOOP pneumonia caused post transplantation. Okay, lung transplant के बाद अगर pneumonia हुआ है, so it means post transplantation, BOOP. Okay, so with this we are done with pneumonia. सब कुछ लिखवा दिया मैंने. So now there will be no issue. Final topic, lung cancer. फटाफट कर लेते. Leading cause of cancer death: presentation is cough, hemoptysis, bronchial obstruction, wheezing, coin lesion on chest X-ray. This is important. Coin lesion on chest X-ray. Non-calcified nodule on CT. Site of metastasis from lung cancer you can avoid. Okay. Okay. So these are the complications: superior vena cava syndrome, Fancos tumor, Horner syndrome, endocrine, that is paraneoplastic, recurrent laryngeal nerve compression, effusion. So these are all the complications that can occur. Risk factors: most common tobacco, secondhand smoke, radiation, environmental exposures. Squamous and small cell carcinoma are central carcinoma and are caused by smoking. This is important. Squamous cell and small cell carcinoma are the central one and they are caused by smoking. So central wale jahan bhi central you think central carcinoma, emphysema, central carcinoma, it is always related to smoking. Okay, so let's see first one, small cell carcinoma, that is the oat cell carcinoma. Okay, it is central, undifferentiated, very aggressive, may cause neurologic, for example Lambert-Eaton myasthenic syndrome. Okay, Lambert-Eaton and myasthenic, this will study in musculoskeletal. Then there will be encephalitis or endocrine problem. Most common will be Cushing syndrome and SIADH. Okay, and histology में आपको कल चीज की स्केल याद रखने, न्यूरो एंडोक्राइन कल चीज की स्केल, डार्क ब्लू सेल्स, chromogramin A positive, neuron specific knowledge. So this is very important. And along with this, you need to remember key the case can be of anything. Okay, the case can be either of myasthenia gravis, Lambert-Eaton syndrome, it can be of SIADH, it can be of Cushing syndrome, anything. At the end, they will give you what tumor is most commonly associated with this. So, okay, so your answer will be small cell carcinoma, that is oat cell carcinoma. Okay, moving on to non-small cell carcinoma, and there are four types. Adenocarcinoma. Adenocarcinoma is peripheral. It means smoking से correlated नहीं होगा. Most common primary lung cancer in people who do not smoke. More common in females. Activating mutations include KRAS, EGFR, and ALK. Associated with hypertrophic osteo clubbing. Just remember clubbing. So non-smoker clubbing. Okay, that's it. Now let's see what over here. As it is adenocarcinoma, it means something related to glands. So there will be glandular pattern. Mucin positive. Okay, that's it. Coming to squamous cell carcinoma, it is squamous cell and it is central, so smoking will be there. Hilar mass is there, cavitation is there, cigarettes is there, and hypercalcemia. Okay, and one important point, it produces parathyroid hormone related peptide. Okay, here there will be keratin pulse. Now you know wherever there is a term squamous, वहाँ पे keratin pulse तो होना ही है. Okay, wherever in whatever the body part, if there is a squamous cell carcinoma, so keratin pulse to hona hi hai. Okay, moving to large cell carcinoma, it is peripheral, strong association with tobacco smoking. Here there is a controversy, it is peripheral, even then there is a tobacco smoking. Okay, may produce HCG, it may lead to gynecomastia. Okay, and it is highly anaplastic, poor prognosis. So here there will be pleomorphic giant cell. Okay, नाउ कार्सिनॉइड ट्यूमर तो सिंपली है, कार्सिनॉइड न्यूरोएंडोक्राइनिन है, 5-HIAA सेरोटोनिन सीक्रेट करेगा. ओके, so this is what it all takes. So cancer is very important. Pakka one question will be there and I will mark it as a high yield, high yield. You should know the histology and you should know the characteristics. Along with that, whether they are central or peripheral. Okay. Moving ahead, Pancoast tumor. So in the Pancoast tumor, also called superior sulcus tumor, carcinoma that occurs in the apex of the lung may cause Pancoast syndrome by invading. Apex of the lung में होता है and it will be invading other structures. That is why this is known as Pancoast tumor. Let's just see. If it invades recurrent laryngeal nerve, there will be hoarseness. Stellate ganglion, so it will lead to Horner syndrome. Superior vena cava, so SVC syndrome. Brachiocephalic vein, to brachiocephalic syndrome, that is unilateral syndrome. Brachial plexus, then shoulder pain, and you won't be able to move the muscles of the hand. Phrenic nerve, so diaphragm, hiccups, and all those problems. Okay, so Pancoast tumor is also high yield. Moving on to superior vena cava syndrome. Superior vena cava syndrome में बस एक बात याद रखनी है. One thing you need to remember: obstruction of SVC, either due to thrombus or tumor, impairs blood drainage from head. So there will be facial plethora. Facial will be turned blue, or it will be swelling, or very red, puffy face, something like that. Okay, blanching after the fingertip pressure. See, this is also we can see. Okay, rest all are common. Rest all are common. Okay, so superior vena cava syndrome is also seen in Pancoast tumor. So just make sure you know that. So with this, we are done with the lung pathology also, respiratory pathology also. Just quickly see pharmacology. Nothing much in pharmacology is there. Okay, just remember the histamine blockers. These are the histamine blockers. Second generation, less sedating. So we mostly prefer second generation. Okay, dextromethorphan. Remember the mechanism. Pseudoephedrine phenylephrine. Remember the mechanism. Here, this is the most important. Endothelin receptor antagonist, PDE5 inhibitors, antagonist. These are the most important drugs. Okay, so antagonize endothelin 1 receptor. So it will decrease the pulmonary vascular resistance. So more and more blood flow will be there. Simple. Okay, and this is hepatotoxin. Bosentan also. They will ask about bosentan also. So you should know the mechanism and what type of drug it is. Coming to PDE5 inhibitors, inhibit PDE5, increasing CGMP, prolonged vasodilatory effect. Contraindicated when taking nitroglycerin or and so it is also used to treat erectile dysfunction. Example sildenafil. Sildenafil जो Viagra के उसमें use होता है. Okay, so that is PDE5 inhibitors. Prostacyclin analog PGI2. Remember the mechanism and flushing and jaw pain. The side effects important है. Okay, this is the overview of the drug that we saw. Let's see और क्या है. Okay, so now let's just quickly see this asthma drug. Okay, so all these are the asthma drugs. First line, obviously, they will be beta blockers, sorry, beta agonists, beta drugs, albuterol, salmeterol, formoterol. Okay, so it means salmeterol and formoterol are long acting, so we mostly prefer them. Glucocorticoids, inhaled wala, flutic acid and budesonide. One important question that they ask over here is: you just pacer or rinse mouth after use to prevent oral thrust. Okay, this is very important. This line is very important. Questions have come. Muscarinic and the antagonist. These two drugs. Ipratropium. In this, tiotropium is long acting. Anti-leukotriene, montelukast and jafilukast. Block leukotriene receptor, this receptor, okay, cis-LT1, okay. Whereas xylutone is a 5-lipoxygenase inhibitor that decreases the conversion of arachidonic acid to leukotriene. This is very important. They will ask you the mechanism of the drug, okay. Moving on to anti-E monoclonal therapy, omalizumab. Binds mostly unbound serum IgE and blocks signaling to FcERI. Used in allergic asthma with increase in IgE levels. Okay. Methylgentin, that is theophylline. No questions have been asked, but you can see this. Okay. Yeah. You can see this. Increase in CAM. That's it. PDE4 inhibitors, roflumilast inhibits phosphodiesterase increase in CAM. So if they increase in CAM, it will lead to bronchodilation. Here also there will be bronchodilation. Okay, तो बस इतना ही याद रखना है, ज्यादा कुछ याद नहीं रखना है अस्थमा के ड्रग्स के लिए. Don't have to remember so many things. Cromolin prevents mast cell degeneration. Anti-IL-5 monoclonal therapy prevents eosinophil depression. As we saw in the immunology, IL-5 is responsible for class switching. Okay, so make sure you know that. So these are the drugs against IL-5, against IL-5 receptor alpha. So here in this you need to remember the receptors and mechanism. That's it. Receptors and mechanism. This is very important. Okay. So with this we finish our respiratory system today. Respiratory system. Yeah, we finished our respiratory system today. It was a long class. I wasted 15-20 minutes in the middle. So it's okay. बाकी overall I think कोई doubt तो नहीं होगा. That's it. That's it for today's class. कल कौन सा system करें? Let's do renal tomorrow. Okay. So you can revise renal and come. And अभी as I told you, don't leave. उठ के पहले बैठ के आधा घंटा बैठ के पहले रिवाइज कर. ओके. सो क्लासेस ओवर. मलिया जी कुछ पूछना है आपको?
No.
तो आपका यूवर्ल्ड कैसा चल रहा है बता दो.
You were, yeah, it's going better now.
पक्का ना? इम्प्रूव हुआ ना? इम्प्रूवमेंट हुआ ना?
हाँ, थोड़ा इम्प्रूवमेंट है. आफ्टर दीज
हम्म.
क्लासेस थोड़ा और ज्यादा आइडिया आ रहा
ओके. अभी तो बहुत कुछ बाकी है. पर मैं जो जो
है.
हाईलाइट
यस.
कराता हूँ ना, आप ट्राई करो उसको याद ही कर लो. ठीक है, मैं जो जो हाईलाइट कराता हूँ उसमें से 80% पेपर आ जाएगा. ओके.
ओके.
इन यूवर्ल्ड भी 80% कवर हो जाएगा. तो वॉट एवर मैं जो हाईलाइट करा रहा हूँ ना, आप उसको तो एटलीस्ट याद कर लो. तो एक्स्ट्रा जो 20% बचा वो जैसे जैसे आप क्वेश्चन सॉल्व करते जाओगे याद आ जाएगा.
ओके.
ओके. एनीथिंग एल्स यू वांट टू आस्क? ओके ना. माइक्रो बराबर रिवाइज कर लो. ठीक है.
हाँ, माइक्रो आई रिवाइज इट अगेन टुडे. टेंशन.
ठीक है. ओके. नो वरीज, नो वरीज. सो दैट्स इट. क्लास इज ओवर.
ओके, थैंक यू.
ओके. बाय बाय.